everyone. My name is Clement Chilambi from Clement Chilambi Medical Tutorials, and in today's discussion, we are going to concentrate or look at tutorial number 5, specifically looking at hemolytic anemia. Okay, so this is hematology, and it is the tutorial hematology series that we are in, and today we will discuss the clinical scenario questions, which are also vital in ensuring that we apply the knowledge that we've learned, and also trying to analyze clinical based questions so that we take a look at the bigger picture. So without wasting much of your time, let's start with our first question. A 25-year-old patient presents with pallor, jaundice, and splenomegaly. Laboratory investigations show features of increased red cell breakdown, including raised and conjugated bilirubin and absent haptoglobins. The direct antiglobulin test is positive. The most likely diagnosis is what? So, as I said earlier, when we are looking at the clinical scenario-based questions, please let's pay particular attention to the patient. Okay, how old is the patient? And then what are the presentations of the patient? Look at this. They have splenomegaly, jaundice, and pallor. And also, what is important is also looking at laboratory investigation. There is increased red cell breakdown. There is increased raised and conjugated bilirubin, and there are no haptoglobulins. Okay, and the direct antiglobulin test is positive. So the clinical scenario questions are very simple because they are reminding you of the notes that you've studied. If you've forgotten, the clinical scenario question will remind you to say, this is what is the lecture slide. What have you not heard here? In as long as you went through those questions, notes, you'll be able to know that I saw something like this, okay? Or I didn't see something like this, and it will give you a clue on how to answer the question. So look at the choices here. What is the most likely diagnosis given the presentations that have been given this question? A, warm autoimmune hemolytic anemia. B, cold autoimmune hemolytic anemia. C, alloimmune hemolytic anemia. D, drug-induced hemolytic anemia. What do you think could be the possible answer? So remember the clinical triad, okay? The classic triad of pallor, jaundice, and splenomegaly points to hemolytic anemia. That is the first thing that you need to realize. Again, you need to realize this now. A positive antiglobulin test, or Coombs test in other words, this one confirms an immune-mediated cause. Okay? It confirms an immune-mediated cause. And then there is an absence of specific triggers like recent transfusions. We've not had any recent transfusions here, or new drugs. There are no new drugs here, along with the commonality of the presentations, which in this case makes warm autoimmune hemolytic anemia, which is option A, the most likely diagnosis. Cold autoimmune hemolytic anemia typically presents with acrocyanosis in cold weather. We discussed this in those short answer questions. So the best answer on question number 1 is warm autoimmune hemolytic anemia. All right. No recent transfusions removes alloimmune hemolytic anemia. No new drugs. That substitutes also drug-induced immune hemolytic anemia. We go to the second question. The second question, a 30-year-old patient with a history of chronic hemolytic anemia presents with acrocyanosis, especially in the cold weather. The laboratory findings show red agglutination in the cold weather, not in the cold weather, but in the cold, and a higher titer of cold autoantibodies. The most likely diagnosis is what? Okay, this is straightforward, and we gave a clue, especially from the previous question, because we know that the purplish discoloration of the extremities in the cold, which is acrocyanosis, is pathognomonic feature of called autoimmune hemolytic anemia. This combined with the laboratory findings, which shows red cell agglutination and higher titers of also cold autoantibodies, signifies that it is really indeed called autoimmune hemolytic anemia. Yeah. So the direct antiglobulin test would be positive in this case, and also just in addition, the direct antiglobulin test would be positive for complement C3d. Yeah, that is what we need to also know. So look at the cold autoantibodies, look at the red cell agglutination, and also look at the chronic hemolytic anemia presentations, which is acrocyanosis in this case, and therefore we are saying that this is called autoimmune hemolytic anemia. Okay. Third question, a newborn infant develops severe jaundice shortly after birth. The most likely cause is what? This is very simple. What are we talking about? A newborn. Who are we talking about rather? A newborn infant. Okay? I have a newborn infant. This newborn infant, what are they saying? It develops severe jaundice. It's not just jaundice, but it's severe jaundice shortly after birth. What is the most likely diagnosis? This is simple. Okay? Severe jaundice presenting within the first 24 to 48 hours of life is highly suggestive of the old autoimmune hemolytic anemia, okay, which is the rhesus disease, the hemolytic disease of the newborn in some other cases, which is actually an autoimmune condition. So rhesus incompatibility is actually a classic cause of this, and you need to also realize that G6PD deficiency can cause neonatal jaundice, okay, but it is less common, this one here, but it is less common as a primary cause in the immediate newborn period compared to the alloimmunization that we've talked about here. So yeah, a newborn infant really points out to autoimmune hemolytic anemia. Okay, a 40-year-old patient with a history of rheumatoid arthritis with fatigue. Okay, let me use this. A 40-year-old patient with a history of rheumatoid arthritis presents with fatigue, jaundice, and splenomegaly. The direct antiglobulin test is positive, and the antibodies are found to be immunoglobulin G. The most likely diagnosis is what? Look at this. We are dealing with who? We are dealing with a 40-year-old patient. Okay? In as far as we are dealing with a 40-year-old patient, what history do they have? Rheumatoid arthritis. And then look at the presentations: splenomegaly, jaundice, and also fatigue. And the test is positive. The DAT test is positive. And the antibodies are of immunoglobulin G form. What do you think is the most likely diagnosis? So the most likely diagnosis in this case, look at this. Look at the presence of autoimmune, right? Rheumatoid arthritis. This is how you find these answers. So simple. Before you even finish the clinical scenario question, you even have the idea of what the answer could be. So we know that the presence of autoimmune disease, which is the rheumatoid arthritis right there, is a non-risk factor for developing another autoimmune condition, such as the warm autoimmune hemolytic anemia. So the findings, look at the findings: IgG. Okay, look at this. Option A saying home autoimmune hemolytic anemia, then B saying cold autoimmune hemolytic anemia. How do we substitute B? We remove B because we are talking about the autoantibodies that are of immunoglobulin G in nature on the surface of RBCs, which is a diagnostic feature for warm autoimmune hemolytic anemia. And therefore, home autoimmune hemolytic anemia qualifies to be the correct answer. This is actually the fourth question. We go to the fifth question. A 60-year-old, okay, a A 60-year-old patient presents with acute onset of dark urine, pallor, and jaundice after starting a new antibiotic medication. The most likely diagnosis is what? A. Drug-induced immune hemolytic anemia. B. Intravascular hemolysis. C. Extravascular hemolysis. D. Microangiopathic hemolytic anemia. What do you think is the correct answer? So microangiopathic hemolytic anemia, extravascular hemolysis, intravascular hemolysis, and all that. So we are talking about who? A 60-year-old patient. What do they have? Dark urine. Okay, presentations: dark urine, pallor, and jaundice. Okay, when did this happen? When did it start? How did it start? A new antibiotic medication. Really, this points out to what? This points out to drug-induced immune hemolytic anemia. Okay, so there is that relationship, a temporal relationship, we would say, between starting a new drug and also the onset of symptoms such as this one, the dark urine and pallor, and also the dark urine there, that indicates hemoglobinuria, right? Which is actually the hallmark of the drug-induced hemolytic anemia. Okay, this is actually a specific type of intravascular or extravascular hemolysis, which is triggered by the medication. All right. So this is at least a very good question, and requires us to have the knowledge of the presentations given here in this question. Now let's go to question number 6 quickly. A 25-year-old patient with a history of recurrent gallstones and mild anemia has a peripheral blood smear showing erythrocytes and poikilocytes. The most likely diagnosis is what? Look at this. This is a very good clue. Okay, erythrocytes and poikilocytes, RBC morphology, recurrent gallstones and mild anemia. What are these two telling us? Okay, so when you look at this, we are dealing with a 25-year-old patient who is still in their adult age. Okay, this is adult. And then when you look at erythrocytes, right? So erythrocytes on the blood smear here, the erythrocytes on the blood smear, this is a diagnostic, okay, a feature of hereditary erythrocytosis. Yes. And one clue also that has led us to come to that conclusion is the recurrent gallstones. So when you look at the recurrent gallstones, this is recurrent gallstones is a common complication of any chronic hemolytic anemia that includes hereditary erythrocytosis. So yeah, we are getting this as the correct answer. Then number 6, a 10-year-old child presents with acute hemolytic crisis after a viral infection. Okay, viral infection, acute hemolytic crisis. Okay, and this one is just a child, a 10-year-old child. The peripheral blood smear shows bite cells and also blister cells. The most likely diagnosis is what? All right, so an acute hemolytic crisis that we're seeing here, an acute hemolytic crisis is triggered by an infection. Okay, this is what we can see. This is how you need to analyze your question. So what is this? Remember the concept of oxidative stress, right? So when an acute hemolytic crisis is triggered by an infection, which of course there is an oxidative stress, this is a clear sign, okay, a classic sign for G6PD deficiency. Okay, clear sign of G6PD deficiency. Why? Look at all those, also the PBS showing bite cells and also blister cells, which are the characteristic morphological findings, okay, of the red blood cells resulting from the splenic removal of the hen's bodies. Okay, so that is the answer that we pick on question number 7 according to the presentations in the question. Okay, question number 8. A 30-year-old patient, okay, with a history of chronic hemolytic anemia. They have chronic hemolytic anemia and also they do have splenomegaly as a history of similar symptoms. The PBS shows what? Microspherocytes. What do you think is the correct answer? Some questions, you just look at this. Since we've tackled other clinical scenario questions, they are giving us a clue. Is it hereditary spherocytosis? Is it hereditary erythrocytosis? Is it Southeast Asian velocytosis? Or is it pyruvate kinase deficiency? So when you look at the triad of the chronic hemolytic anemia, there is a triad for chronic hemolytic anemia. A classic triad is that of hemolysis, number 1, splenomegaly, number 2, and a positive family history. Please note these things. A positive family history. All these suggest what? A hereditary disorder. It's hereditary. Okay. So the presence now of microspherocytes, the one that we are seeing here, on the blood smear, is a pathognomonic feature for hereditary spherocytosis. So we get A to be the correct answer. All right, question number 9. A 45-year-old patient with a history of artificial heart valve replacement presents with fatigue, jaundice. Okay, 45-year-old patient, what they have, presents with artificial valve replacement, and then they have fatigue, they have jaundice, they are schistocytes on the peripheral blood smear. Okay, the most commonly diagnosis is what? Okay, so the most commonly diagnosis, look at this, right? We have a 45-year-old patient, the artificial heart valve. Okay, so the artificial heart valve here, the one that you're seeing here, the artificial heart valve is a classic cause of mechanical hemolysis. Okay, I think we did discuss this in other tutorials. Artificial heart valve is a classic cause of mechanical hemolysis. The presence of schistocytes, okay, presence of schistocytes, which is RBC fragments on the smear, defines this scenario as a red cell fragmentation syndrome, which is of the macroangiopathic type. So microangiopathic hemolytic anemia refers to that damage from those fibrin strands in small vessels, not large prosthetic surfaces. And therefore, what are we saying? We are saying that red cell fragmentation syndrome is the correct answer in this case, okay, because of the presence of schistocytes, and also we are talking about the mechanical hemolysis, okay, which is of macro, not micro, but macro angiopathic type. Okay, question number 10. A 20-year-old patient with a history of prolonged marching or running presents with dark-colored urine. Okay, dark-colored urine here. And then this one is a 20-year-old patient, and then prolonged marching or running, keywords. Peripheral blood smear does not show red cell fragments. This is also telling us something. Does not show any red cell fragments. What is the most likely diagnosis? A, match hemoglobinuria, B, intravesicular hemolysis, extravesicular hemolysis, and microangiopathic hemolytic anemia. Which one do you think is the correct answer? When we talk of question number 10, we really look at this. There is the history of the strenuous exercise leading to what? Hemoglobinuria, which is dark-colored urine, right? And this itself is a classic sign of match hemoglobinuria. Okay, it's a classic sign for match hemoglobinuria. The key distinguishing feature from other fragmentation syndrome is the absence of what? So the fragmentation syndrome, remember, there's absence of what? The schistocytes, okay, on the blood smear. So this actually, that's why the peripheral blood smear does not show red cell fragments, is actually a good keyword as well. A 30-year-old patient with a history of malaria presents with severe intravesicular hemolysis. Okay, severe intravesicular hemolysis, acute renal failure, and hemoglobinuria. What is the most likely diagnosis? So look at this. This is this is a triad also. These are very, very visible signs. I'm going for black water fever. Why? Black water fever is very specific. In other words, it's a specific and a severe complication of what? Plasmodium. Look at this. History of malaria. So a severe complication of of Plasmodium falciparum malaria, which is characterized by what? The intravesicular hemolysis itself, the hemoglobinuria, this one here, which refers to dark black water urine. That's the term black fever, isn't it? And the acute renal failure. Simple. Okay. Then question number 12, I mean. A 25-year-old patient with a history of Wilson's disease, copper toxicity, okay, presents with acute hemolytic anemia. The most likely cause is what? They have told us the condition. Now let's talk about the cause. I think I have already talked about this. So look at this. In Wilson's disease, acute hemolytic anemia that we are seeing here, there is acute hemolytic anemia, occurs due to what? Due to the sudden release of copper from the liver, okay, to the bloodstream, or from the liver into the bloodstream. That's correct English. From the liver into the bloodstream. Now, copper itself is a potent oxidant that damages these RBCs, and apart from damaging RBCs, yeah, the main thing that we can talk about is just the damage of RBCs. That leads to what? To hemolysis, right? So the correct answer that we get here is B, high levels of copper in the blood. A 40-year-old patient with a history of severe burns, okay, severe burns, presents with acanthocytes and spherocytes, okay, acanthocytes here and spherocytes on the peripheral blood smear, PBS, we all know this. The most likely cause is what? Okay, look at this patient, severe burns. So what do you think? How do you analyze this question? Look at this, severe burns first of all. Severe burns is to be taken care of here. So severe burns cause the direct thermal damage, right? It causes the direct thermal damage to red blood cells, which can manifest on blood smear as what? Acanthocytes, the SPA cells in SPA, this pairing here, the SPA cells, okay? In some other, in case you get confused. So a 40-year-old patient with a history of severe burns presents with acanthocytes. So these severe burns causes the damage to RBCs, and that's why they manifest on a smear as acanthocytes, and not only acanthocytes but also as spherocytes. Okay, now this is actually a form of acquired hemolytic anemia. Okay, it's acquired because of severe burns. So I've already explained this. The answer is the damage to red cells due to the burns. That's the most likely cause, right? A 35-year-old patient with a history of idiopathic thrombocytopenic purpura presents with hemolytic anemia. The most likely diagnosis is what? So I'm always circling the age, because age is a very good indicator of some parameters that we might not be able to observe in some age groups, right? So age always is actually the most important. That's why the question is not starting just as a patient with a history, no, a 35-year-old, because it's actually telling us something. Now, look at this. The history of idiopathic thrombocytopenic purpura presents with hemolytic anemia. Does this ring anything to you when you look at this combination, this tag team here? So look at the, I'll go direct with this one. Evans syndrome is the answer. Evans. Why Evans syndrome? Because the definition of Evans syndrome itself is that it is a simultaneous or a sequential presence of two conditions, the immune thrombocytopenic purpura and also the autoimmune hemolytic anemia, right? Just that is enough. A 50-year-old patient with a history of chronic hemolytic anemia and splenomegaly has a peripheral blood smear showing ovalocytes and some cells with a slit-like central pallor. The most likely diagnosis is what? A, hereditary spherocytosis, B, hereditary erythrocytosis, C, Southeast Asian ovalocytosis, D, pyruvate kinase deficiency. So a 50-year-old patient with a history of chronic hemolytic anemia presents with this. So look at these words: chronic hemolytic anemia, 50-year-old patient. Okay, there is splenomegaly, what's the smear showing? Ovalocytes and the slight or slit-like central pallor. Okay, so what's the best option here? We have hereditary spherocytosis, we have hereditary erythrocytosis, Southeast Asian verocytosis, and pyruvate kinase deficiency. So the description of ovarocytes with a slit-like central pallor, okay, ovarocytes with a slit-like central pallor is the classic morphological finding in the Southeast Asian ovarocytosis. Just that, we're done. A 30-year-old patient with a history of chronic hemolytic anemia presents with severe, look at this, severe anemia, reticulocytosis, and a low myeloid erythroid ratio in the bone marrow. The most likely diagnosis is what? The most likely diagnosis is number 16. Look at this. Okay, pyruvate kinase deficiency. Why pyruvate kinase deficiency? You would say no, hemolytic anemias cause reticulocytosis, but pyruvate kinase deficiency itself here in this case is notable. Why? For being a chronic, okay, for being a chronic lifelong, okay, being a chronic lifelong hemolytic anemia. This one here, the low myeloid to erythroid ratio, indicates the bone marrow erythroid hyperplasia, right? Which is just a compensatory response to this chronic hemolysis that we've had here. Our G6PD deficiency we're seeing on D here is typically episodic, not really chronic. No. Okay, 25-year-old patient with a history of recurrent infections presents with acute. Okay, recurrent infections presents with acute hemolytic crisis. The peripheral blood smear shows Hae's bodies in the reticulocytes. The most likely diagnosis is what? This is simple. The most likely diagnosis is a G6PD deficiency on question number 17, because Hae's bodies are a hallmark of oxidative damage to hemoglobin, and their presence in patient with an acute hemolytic crisis is highly suggestive of G6PD deficiency. We have Hae's bodies and reticulocytes here. Yeah, and infections, actually, in this case, have they mentioned any infections? Infections, yes, recurrent infections. Infections are the most common trigger. Yeah. A 40-year-old patient with a history of chronic hemolytic anemia has a peripheral blood smear showing erythrocytes and poikilocytes. The patient's sibling also has similar findings. Look at this, history. The most likely diagnosis is what? Hereditary spherocytosis, hereditary erythrocytosis, Southeast Asian ovarocytosis, pyruvate kinase deficiency. That is question number 19. Now, there is a finding of erythrocytes, right, which substitutes this. This has been substituted. And then there's a finding of a positive family history, which signifies hereditary erythrocytosis. So B. So what? The patient's sibling. Okay, the patient's sibling also has similar findings. What does this tell you? It's hereditary. If I'm a student who's answering this question, I will remove C and D. Okay, disqualify C and D and remain with these two. Now this one is just to substitute erythrocytes. No, we are looking for erythrocytes, yes, not spherocytes. So many other times when we're given a clinical scenario question, we think the lecturer is trying to make sure that they make us think, no, they're actually assisting us in answering the questions, actually. Okay, because they are not even looking for hidden things. No, they are looking for a more sequential or a more logical reasoning at arriving at a specific answer, a particular answer that is needed. Okay. All right. So B is our correct answer. Question number 19. A 35-year-old patient with a history of methodopa use presents with hemolytic anemia. Okay, methodopa use is a drug, isn't it? Presents with hemolytic anemia. Okay. The DAT is positive. The DAT is positive. What's the most likely diagnosis? and this is a 35-year-old patient, and they have a history of methodopa. So methodopa, first of all, is keyword. It's one that we're looking for. So is it drug-induced immunohemolytic anemia type 3, drug-induced immunohemolytic anemia type 1? Is it drug-induced immunohemolytic anemia type 2, or autoimmune hemolytic anemia? So methodopa, a 35-year-old patient with history of methodopa. So methodopa itself is a classic example of a drug that can induce, of course, a true autoimmune hemolytic anemia. Sometimes it is classified as type 3. Okay, so the antibodies that you're seeing here are directed against what? The antibodies are directed against the patient's own RBCs, independently of the drug, right? Now, the clinical and the laboratory picture is actually distinguishable, okay, from the idiopathic warm autoimmune hemolytic anemia, and the DAT is positive for IgG. What does this tell us? This tells us that it is a warm autoimmune hemolytic anemia. Okay, we are saying methodopa is just a classic example of a drug that can induce the autoimmune hemolytic anemia. Okay, sometimes which is classified as class 3. But when you look at this, the direct antiglobulin test is positive. Okay, and the antibodies are directed against the patient's own RBCs, independent of the drug. So all these really tells us that it is autoimmune hemolytic anemia. Then number 20, a 20-year-old, number 20, a 20-year-old patient, 20-year-old with a history of severe bacterial sepsis, presents with microangiopathic hemolytic anemia. They are presented with thrombocytopenia and also renal dysfunction. What is the most likely diagnosis? So the most likely diagnosis in this case, we have, okay, look at this. Look at this. Is it thrombotic thrombocytopenic purpura? Is it disseminated intravascular coagulation? Is it microangiopathic hemolytic anemia due to sepsis? Is it all of these things? So first of all, severe sepsis can trigger, one, disseminated intravascular coagulation, right, which is a classic cause of a microangiopathic hemolytic anemia due to sepsis. 2, we mark that. And then the triad of the microangiopathic hemolytic anemia due to sepsis, thrombocytopenia, and renal dysfunction, actually. Renal dysfunction, all these, the triad, signifies, or I should say, it's a common to both disseminated intravascular coagulation and also thrombotic thrombocytopenic purpura. Have you seen how TTP has qualified here? So in this context, sepsis itself is the most likely underlying cause of the disseminated intravascular coagulation. So this sepsis here. And therefore, what are we saying? We are saying that all of the above are the correct choices. 21, a 30-year-old patient. A 30-year-old patient with a history of chronic hemolytic anemia presents with severe jaundice and splenomegaly. The peripheral blood smear shows many red cell fragments, schistocytes. The most likely diagnosis is what? Okay, so what do we have on the blood smear? We have schistocytes, and then we have jaundice, and we have splenomegaly. All right, so is it hereditary spherocytosis? Is it hereditary erythrocytosis? Is it red cell fragmentation syndrome, microangiopathic hemolytic anemia? Okay, look at this. So when you look at this, the presence of numerous schistocytes, first of all. This is a case of chronic hemolytic anemia. So the presence of these numerous schistocytes defines what? Red cell fragmentation syndrome, right? This is an umbrella term for that includes both microangiopathic, which is Macro, when you say macro, we talked about the artificial valves. So macroangiopathic, which is the prosthetic valves, and microangiopathic, right? Like the TTP and DIC causes. Okay, so we pick this as a normal answer. We even found this question somewhere. Yeah, a 25-year-old patient with a history, 25, they have a history of rheumatoid arthritis, presents with, I think we did discuss this question as well, jaundice, fatigue, and splenomegaly. Okay, that is positive, that is positive. Antibodies are found to be IgM. What's the most likely diagnosis? Is it, okay, this one we already said it, isn't it? We already said this. So look at this, the classic finding of IgM. Okay, IgM. Did we discuss this? I think we did discuss the warm autoimmune. So the finding of IgM, immunoglobulin M antibodies on the RBC surface, what does this signify? This signifies the cold autoimmune hemolytic anemia. Warm autoimmune hemolytic anemia associated with IgG antibodies. We're just going to end here. Okay, cold autoimmune hemolytic anemia. A 40-year-old patient with a history of artificial heart valve replacement presents with fatigue, jaundice, and schistocytes on the peripheral blood smear. The patient also has a low platelet count and abnormal clotting tests. What is the most likely diagnosis? Okay, so the patient has a low platelet count and abnormal clotting test. The most common likely diagnosis is what? Okay, so let's analyze this question. 40-year-old patient. Okay, artificial valve. Macroangiopathic. Macroangiopathic. So micro here, no. Okay, let's go direct to the answer. Look at this. This patient is 40-year-old and they have a history of artificial heart valve. Okay, and they've presented with fatigue, they've presented with jaundice, and also schistocytes on a PBS. And look at this now. These are the parameters: low platelet count and abnormal clotting tests. What's the most likely diagnosis? So let's explain this. Number 23. So first of all, the prosthetic valves, right? The artificial heart valve causes red cell fragmentation. Okay, it causes red cell fragmentation syndrome. The concomitant thrombocytopenia and abnormal coagulation tests that we are seeing here, because low platelet count, thrombocytopenia, this one, and abnormal clotting count, clotting tests, I mean, these suggest that this has triggered or is associated with disseminated intravascular coagulation, which is actually a serious complication. And therefore, we have no doubt that the choice C is the best as compared to other choices that we have. Okay. A 30-year-old patient with a history of chronic hemolytic anemia, okay, chronic hemolytic anemia and splenomegaly has a family history of similar symptoms. The peripheral blood smear shows microspherocytes, and also the direct globulin test is negative. This is a good sign. What does this tell you? Okay, so the negative DAT itself, this one is the biggest clue. The negative direct globulin test rules out this autoimmune thing. Okay, it rules out the autoimmune cause. And then the combination of chronic hemolysis, where is it? I saw something like chronic something. So chronic hemolysis, okay, it's chronic hemolytic anemia, you can mark this. So a combination of chronic hemolytic anemia, the combination of the family history itself, and also the splenomegaly, which we are seeing here, the splenomegaly here, and not only the splenomegaly, but microspherocytes on the PBS. Okay, we've already talked about the DAT, which is negative. These are diagnostic for hereditary spherocytosis. Yeah, they are diagnostic for hereditary spherocytosis. All right. A 25-year-old patient with a history of prolonged marching or running presents with dark-colored urine. The PBS shows no evidence of fragments. What am I doing? Okay, no evidence. There's no evidence of red cell fragments, and also we have a clue of prolonged marching, running, and then this is a 20-year-old patient, and most importantly, hemoglobinuria, which is the dark urine here. What do you think is the correct answer here? I think we did repeat this question. There are no schistocytes here, so likely is much hemoglobinuria. This is a repeat. So this is where we end our clinical scenario based questions on hemolytic anemia. Hope you enjoyed the whole session, and hope this whole thing, the questions has taught you something about the hemolytic anemias. So the only things that are remaining now is to discuss the essay questions, and also the essay questions themselves, to build up on knowledge. And also there are some lectures which will actually be uploaded, so first watch those lecture videos and then come here and let's look at the questions themselves. Thank you so much for attending and also for listening. See you in the next tutorial.